Behalf of Medicine 5. So, presenting a 64-year-old gentleman, Mr. P, who presented to the emergency department with complaints of fever since 2 days, reduced appetite since 2 days, and altered sensorium for 1 day. History of presenting illness: he was apparently well in his usual state of health until 2 days back when he developed a fever. The fever was high grade, intermittent with chills, and it was relieved with paracetamol. Along with the fever, he also had some reduced appetite for the last 2 days. And for the last 1 day, he has developed an altered sensorium in the form of excessive drowsiness and altered irrelevant speech for 1 day. And he's a patient who's on a regular Foley's catheter for the last 4 to 5 months because of benign prostate enlargement. He had an episode of acute retention of urine in February, and prior to planning for surgery, he has been on a continuous catheter, which he changes once in 1 month. And the last change of catheter was 25 days back. He did not have any history of cough, breathing difficulty, headache, vomiting, seizures, loose stools, or other problems. Past history wise, he had multiple issues and he had multiple hospital admissions in the year 2023. He's a known diabetic for the last 3 years on insulin with macrovascular complications of cerebrovascular accident and microvascular complications of nephropathy, neuropathy, and retinopathy. He's hypertensive for the last 3 years. He was admitted with the community-acquired pneumonia in January 2023. And that time he also had an anemia and his stools had grown strongyloids and he was treated with ivermectin for the same. He has benign prostate enlargement and he had an acute retention in February 2023, and since then he's on an indwelling catheter. He has a history of exogenous steroid abuse for knee pain and backache for the last 3 to 4 years. And when he presented in January 23, his random cortisol was found to be low. And in view of adrenal insufficiency, he was started on replacement dose of steroids. He had 2 cerebrovascular accidents in 2023, and his functional status, he was bedbound, and he was on NG feeds. He was able to verbalize, and he was passing stools and urine in a diaper. He was passing stools in a diaper, and he was catheterized. And he had an admission in May 2023 with urosepsis and septic shock, and his cultures at that time had grown an E. coli. There was also another admission in May with symptomatic hyponatremia with seizures. And personal history: he doesn't smoke or consume alcohol. He was on an NG feeds post the second cerebrovascular accident. Examination wise, he presented in shock with warm peripheries. His blood pressure was 80-50 millimeters of mercury on 15 mics of noradrenaline. His pulse rate was 108 per minute. He was tachycardic with peripheries were warm, and the temperature on admission was 101 degree Fahrenheit. His sensorium was also low, with best documented sensorium being E3, V3, and M5, and there was pallor with bilateral pitting pedal edema. Systemic examination wise, the cardiovascular system, respiratory system were within normal limits. Abdomen, there was some left renal angle tenderness felt. And central nervous system, he was drowsy. He was not oriented to time, place, or person. However, there were no meningeal signs like neck stiffness, Kernig sign, or Brzezinski's sign. Best observed power was 3/5 in both upper and lower limbs. Plantar or extensor on the left side. Pupils are equal and bilaterally reacting to light. A sensory system, cerebellar system could not be examined. And so this is an elderly gentleman who's a diabetic and hypertensive who has now presented with fever, reduced appetite, and altered sensorium. He's on a Foley's catheter because of benign prostate enlargement. What are your differentials? Log into Slido and share your differentials. Code is 1642341. So one has said septic encephalopathy, the other one has answered as catheter-associated urinary tract infection. Like you said, the first differential we considered was a septic encephalopathy, secondary to a urinary tract infection. Other differentials we considered was an acute meningoencephalitis. However, there were no meningeal signs. Other possibilities was a community-acquired pneumonia. Because of the previous admission with electrolyte disturbances, symptomatic seizures, we also considered metabolic encephalopathy, like dyselectrolytemias or hypo or hyperglycemia. Because of the chronic steroid abuse, we also considered adrenal insufficiency as a differential, and also an acute CVA as another differential. And we investigated towards the same. And investigations wise, hemoglobin was 7.8. Total count, total count was elevated 34,300 with a left shift with 84% neutrophils. He had an AKI with creatinine of 3.38 and urea of 105. LFT was within normal limits. Urinalysis showed 3 plus bacteria with 172 WBCs. Procal was 69 at presentation. We did urine cultures and blood cultures. His ultrasound abdomen showed left.
Go back to the previous.
Cultures, I put it in a separate slide. Ultrasound abdomen showed a left moderate HUN with a stricture in the left urethra. And cultures, on the day of admission, the blood culture which was sent grew pan-sensitive E. coli, and his urine culture grew multiple organisms, which included E. coli, Pseudomonas, and Klebsiella. The second culture, which was done on the 28th of July, grew Klebsiella pneumonia, the same which was isolated in the urine, and it was pan-resistant, and it was a carbapenemase resistant organism. And initially, this patient was started on meropenem, and based on the sensitivity pattern, he was upgraded to ceftazidime avibactam with aztreonam. And he responded partially to the antibiotics. He was afebrile for some time. There was some improvement in sensorium. We were able to tap the inotropes. But then again, repeat blood cultures on the 3rd of August. 3rd of August grew enterococcus in the blood. And this was vancomycin sensitive. We again had to add vancomycin to his antibiotics. And post starting on ceftaz-avi, aztreonam, and vancomycin, repeat blood cultures on the 10th of August showed no growth. However, patient had some worsening on the 10th of August in the form of again hypotension, tachypnea, worsening saturation, and total counts were again on the rising trend on the 10th of August. This is the trend of his WBC counts. Initially presented with the counts of 34,300 with left shift and neutrophilic predominance. Again, towards the 9th and 10th of August, his count started going up. Again, he developed fever and his cultures grew enterococci at this point of time. So this is a patient who has come with multiple gram-negative organisms in his urine, in his blood. We were worried where is the source of the pathogens, and most of them were gram-negative organisms. We were thinking why he's growing so many organisms in his blood. What is predisposing him to his sepsis? One could be his chronic steroid abuse. The other could be his uncontrolled diabetes. And is there anything else which could predispose? Is what our question was. So finally, we sent a stool parasite for this patient, which grew Strongyloides stercoralis again. He had this same larva in his stools in January 2023. He was treated with ivermectin, and his repeat stool parasite was negative. However, again, his stool parasites which we sent again grew Strongyloides stercoralis. So is there any association between this strongyloidiasis and gram-negative sepsis is what our question was. So I'd like to talk about strongyloides hyperinfection in this case and how it predisposes a patient to gram-negative sepsis. So strongyloides stercoralis, the mode of spread is usually by a skin contact with the contaminated soil. It can also spread via fecal-oral route and by person-to-person transmission. However, the most predominant mode of spread is by skin contact with contaminated soil. So this is the life cycle of strongyloides. There is two different parts in the cycle, the free living cycle and the parasitic cycle. Free living cycle occurs outside the human body. The parasitic cycle occurs within the human body. Infection occurs when the infected filariform larva penetrate the intact human skin. It penetrates the skin, goes into the lymphatics or the blood vessels, reaches the alveoli. From the alveoli, it goes into the tracheobronchial tree and it's swallowed. Then it enters the GIT. In the GIT, this filariform larva mature into adult worms. These female worms lay eggs again, which again hatch into rhabdiform larva. These larvae can cause an auto-infection. It can penetrate the gut mucosa, again penetrate the gut blood vessels and cause an auto-infection, causing a repeated cycles. The other form can get excreted in stools and again form larvae and worms in the soil. Peculiarities about this worm, it can complete a life cycle in a single host and it can cause auto-infection, and immunocompromised patients, strongyloides causes an exaggerated auto-infection. And the clinical spectrum of strongyloidiasis, it can present as acute strongyloidiasis or a chronic strongyloidiasis. It can present as, in patients who are immunocompromised, it can present as a strongyloides hyperinfection or a disseminated strongyloidiasis. So what is piggyback? This is a phenomenon where when there is repeated auto-infection with strongyloidiasis in an immunocompromised host, when the gut translocation occurs, the strongyloides larva also carries the gram-negative organisms with it into the bloodstream. This in turn predisposes the patient to multiple sepsis with multiple gram-negative organisms from the gut mucosa. Other factors how strongyloidiasis predisposes a patient to sepsis is by causing ulcerations in the intestinal mucosa, or by causing obstruction of the small intestine, or by causing adynamic ileus. This hyperinfection syndrome has a mortality rate of more than 85%. Usual risk factors for a strongyloidiasis hyperinfection is an immunocompromised status, which like examples include HIV, HTLV infection, malignancies, congenital immunodeficiencies, patients who are post-hematopoietic or solid organ transplants, and patients who are on long-term steroids or cytotoxic drugs. And usually subclinical infections, patient can have eosinophilia. Patients with hyperinfection, they usually do not have peripheral eosinophilia in their blood. And I'd like to highlight one study done in CMC assessing the risk factors which predisposes a patient to strongyloides infection. In this CMC study, they retrospectively analyzed charts of patients, and they found that infection with HIV and usage of corticosteroids predisposed patient to strongyloidiasis infection. This was just infection, not a hyperinfection. And one such cases they studied was a patient with SLE on prednisolone who developed E. coli septicemia, and with the stool parasites being positive for strongyloidiasis, and this patient ultimately succumbed to her illness. And this is one another Thailand study which assessed the risk factors for strongyloidiasis hyperinfection and the outcomes of the same. They found out that chronic strongyloidiasis and hyperinfection were common in immunocompromised hosts. Almost 100% were immunocompromised to get a strongyloidiasis hyperinfection. The most common immunocompromised status was an autoimmune disease in 45%, followed by hematological malignancies and HIV infection. And the most common presentation of hyperinfection was with a pneumonia or a clinical sepsis. And corticosteroid usage history was there in around 89% of the individuals with strongyloidiasis hyperinfection. And blood cultures, 12% of the individuals in the study had a positive blood culture, and most of them were gram-negative organisms like E. coli, Klebsiella, and Pseudomonas. And around 5 patients had a positive gram-positive organisms like Staph aureus or a Streptococcus species. And the study also assessed the cure rates with common antiparasitic agents and found that the cure rate was better with ivermectin than albendazole. And this is one another study which assessed the severe strongyloidiasis in corticosteroid treated patients, and they studied this to find out what were the most common organisms causing sepsis in patients with hyperinfection of strongyloidiasis. They found out that the most common organism was E. coli, followed by Klebsiella, followed by Pseudomonas. Most common site of infection was bloodstream in 44%, followed by CNS involvement in 23% of the individuals. Current diagnostic methods, most common methods used is a stool microscopic examination, which has a sensitivity of less than 50%. Sensitivity gets better by increasing the number of samples, like 2 or 3 samples increases sensitivity. There is also stool PCR or stool agar plate cultures available, and newer techniques like ELISA are also coming up with improved sensitivity and specificity. And treatment aspects, initial treatment was done with thiabendazole, but however, studies case reports showed that incidence of adverse effects was higher with thiabendazole compared to ivermectin. Patients treated with thiabendazole had higher incidence of disorientation, fatigue, and nausea compared to patients treated with ivermectin. And this is one another meta-analysis in Cochrane, which compared albendazole with ivermectin for treatment of strongyloidiasis, and they found that the cure rates were higher with patients treated with ivermectin than patients treated with albendazole, and it was statistically significant. There was no significant difference in adverse events between albendazole and ivermectin. And the same study also compared thiabendazole with ivermectin and found that the incidence of adverse events was lesser with ivermectin compared to thiabendazole, and the cure rates were similar between both the drugs. So strongyloidiasis hyperinfection, usually when there's a simple infection in an immunocompetent individual, we can treat with ivermectin 2 doses, 12 mg 24 hours apart, whereas in hyperinfection, we usually treat with 12 mg of ivermectin, which we continue for at least 2 weeks. And continued daily stool examination is necessary to show clearance of the organism. And if there is a positive stool parasites, which is positive for strongyloidosis on day 3, we usually add albendazole also to the regimen. And if persistent immunosuppression is needed, like patients with SLE who need long-term steroids, it's better to continue ivermectin once monthly for at least 6 months. There are only a few case reports which support this. There are not much of studies on this. And this,
how much more do you have? How much more do you have for your last slide?
So disseminated strongyloidosis, this is where it's another spectrum of infection where this organism spreads to multiple organs like lungs, liver, brain, heart, and urinary tract. So our patient, we initially treated with meropenem, upgraded his antibiotics to Ceftas, Aviastrionum, and because his blood culture grew enterococcus, we had to add vancomycin also. For the stools, we had dewormed with ivermectin, but however, our patient worsened on like on day 15, and he had some worsening saturation, tachypnea. X-ray had showed some new infiltrates also. We explained the poor prognosis to the relatives, but the relatives opted for comfort care and they wanted to take him home for further care. So take-home message is any sepsis in a steroid-treated patient or an immunocompromised patient with GI symptoms and sepsis growing multiple GI organisms like gram-negative organisms, always consider the possibility of a strongyloidosis infection, and repeated stool examinations is a must. Thank you.
Thank you so much for that nice presentation. I just one point which I always feel, just as you pointed out about the sensitivity of the strongyloids, identification in a stool examination is very low, it's less than 50%. My tendency actually is when I have a patient with a gram-negative sepsis, many times who may be immunocompromised some way or the other, is to give them ivermectin. I just give it to them. There's no harm done. 2 doses, give it off. You can keep screening. So that's one thing which I do in my practice, mainly because of the, there's really no harm done and probably maybe benefit. As you said, no, your other tests really can't help identify, like eosinophilia, it won't be there in a person who's got a hyperinfection syndrome. So there are, in addition to gram-negative sepsis, we keep talking about gram-negative sepsis for strongyloids infection. Anything else? You did mention it in your slides, but I just want to reiterate because that's a very important thing to think about when you see patients, any other clinical manifestation of a strongyloids gram-negative infection. Any other way they can present other than gram-negative bacteremia? He did mention it in one of his slides. And I think there's some reports from CMC also. So you have a meningitis, a gram-negative meningitis. That is also something which you need to think about, like don't accept it as, So if you see a gram-negative meningitis, think strongyloids, probably treat, investigate, and treat simultaneously. Just one other question for you all and for the rest of the group sitting here. Any other parasite which can be associated with gram-negative sepsis? I mean, you shouldn't go back thinking that only, gram-negative sepsis, piggyback, strongyloids. Any other parasite? Commonly seen? I mean, which maybe Andhra predominant? Giving some clues. So we have severe malaria infection. Okay, we all know that, malaria, the parasites can clog up the microcirculation of the gut and you can have a gram-negative sepsis. So these are all things to think about when you have a gram-negative sepsis. Okay, so these things to investigate for and look for. You did mention about procalcitonin in your this thing. What's the role of procalcitonin?
In downgrading antibiotics.
Yeah, so as a diagnostic tool, not really very useful, but for downgrading, it's useful for de-escalation. Any other questions from?
Did you demonstrate the lab? Was it only in the school or
we didn't actually test this lab.
Why are you calling it infection? Yeah,
in the background of immunocompromise.
What was he? I came late, sorry. So was he HIV? No.
He's on
He was
steroids,
on law.
long-term steroids, and diabetic on insulin, I think.
Yes.
His cultures were repeatedly positive despite appropriate antibiotic therapy.
He
He
repeated
got
the
new
cut.
bugs. I think he got new bugs. No, first was an E. coli, then was a Klebsiella, then was an Enterococcus. 3 different bugs in the same admission.
On the
After
10th,
treatment.
it was negative, and we had different organisms. The first one was a E. coli on the 27th, and 28th it was Klebsiella, and the third
Not
of
the same, but
Any other questions?
and was he hospitalized repeatedly? Why did he have only
Yes, sir.
bugs in this week?
he had some 5-6 admissions in the 1 year.
He's, I mean, so that's what another point which I was coming to. This is a gentleman who's had multiple hospital admissions. He's got an indwelling catheter which has been there for months. Choice of antibiotics wise, what would be? You've got a guy who comes in with shock, who's been in and out of hospital. I don't know whether it was CMC. What would be your choice of first antibiotics?
Meropenem.
I don't know. To me, I think he's a high risk for a carbapenem resistant organism, having been in hospital and having an indwelling organism. But I don't know whether the reason for choice for meropenem was more to do with cost and the fact that he was bedbound, and maybe there were some limitations put to care. I'm not sure. From the story that you had presented, this was a gentleman who was actually bedbound, right? Bedbound on a indwelling catheter. So I'm on indwelling Foley's catheter. I mean, just something to think about when you have such a patient coming in. I think, and you have a patient. Suppose it's any other patient coming in from home, been in and out of hospital. Someone who's not bedbound. We need to think. Hitting hard with the right antibiotic for a patient who is in septic shock. That is very, very important. So, deciding which antibiotic to choose should be based on the patient's clinical scenario. I mean, that's what I feel. So you hit hard, then you can de-escalate, once you have your cultures coming back. Thank you so much for the presentation. We'll go on to the next case.